Please go ahead.
Yeah, thank you.
So as I was explaining, as a multiple myeloma researcher, I was involved in clinical trials with genetically engineered T cells called CAR T cells for the last several years. And what we realized in myeloma trials was that the response rate and the duration of response was quite unpredictable, unlike the responses seen in acute leukemia trials or even large cell lymphoma. And being a lab scientist as well as a physician, my curiosity was in how can we pick apart the patients that are responding or going to respond for a long time, or going to not respond or have severe toxicities and not benefit from the CAR T therapy. So about 6 months before COVID pandemic started, we had actually started analyzing patients using a cytokine platform that I had co-developed with the immunologist here. The platform was very simple. Designs in 2 hours, and it uses microchips. These are microfluidic chips that we can custom design for whatever cytokines of interest you may have. And then you put a tiny drop of serum in the chip. The machine spits out the report in 2 hours, and then you can use that to guide your understanding of the patient and potentially management of the patient. So we set this out not as a way to understand COVID, but as a way to understand CAR T therapy and toxicity and response to CAR T therapy. It just so happened that by chance, 6 months later, COVID hit, and it really hit New York badly. We were the biggest COVID center in New York. We had over 2,000 patients in the hospital at the peak. And we had actually made hospitals not only in the hospital, but in the lobby of the hospital and in Central Park, which is the park outside the hospital, to just have enough bandwidth to treat all the patients. Thankfully, that is all past now, and I was just on campus for the last 2 weeks. I didn't see a single COVID patient now, which is amazing. We were transplanting patients, giving high dose chemotherapy, giving CAR T, and really there's a stark change from where things were in March and April. So with that, I'm going to share some slides about a study that we launched around the time COVID started at our institution, using this platform that was used for cancer patients to understand the cytokine storm. And I'm happy to report that the study has been accepted for publication in a prestigious journal, Nature Medicine. The lead author and group is my immunology colleague, Sasha Nyatik, and I'll show you his photo in one of the slides. So if I can share my screen, that would be great. I think you may have to allow me to share screen.
Oh, hold on just a second. So would you please send me the link to this Nature Medicine article? Okay.
Yeah, I think as soon as it comes out, I'll be able to send you. Maybe I can send you a preprint right now. But
okay.
All right. Can you tell me if you're seeing the screen?
Yes, I can. So everybody can see the screen.
I'm sorry, Almaz. 1 minute. Наши врачи не могут присоединиться, потому что они не получили разрешения от него войти на конференцию. Кардиологи мне пишут.
Ну, я всем дал здесь практически. Yeah, sorry, we speak in Russian.
I'm sorry, yes, I'm sorry.
No problem. Just let me know if there's a question, and this should be interactive. Please feel free.
So now 8:00 p.m. and people just joining. They came from work, and so I giving permission now to join. There's several other people still coming. So I think we have about 25 or 30 people that joined.
Sorry.
Would you prefer if we waited for a minute for people to join?
Yeah, just give a few minutes. Dr. Parekh, do you remember I also asked you to maybe to set up time for the personal interview on COVID-19 for the TV? So
yeah, I was thinking actually we have a couple of people. We have a new center actually for post-COVID management. So I was going to ask your permission. Maybe I can reach out to the center and have one of the physicians there who are following the post-COVID patients more closely to be on your interview. I think they will be better suited. I was, as I said, involved in this study and involved in the acute care of COVID patients, but now I've switched back to my oncology role. So you might get somebody from the COVID center who has ongoing care in this regard. So we can discuss that, I think, later offline. I'm sure we can find the appropriate expert for that.
Yeah, we can do both actually. We can discuss cytokine storm and with the level of your expertise. And if you also direct me to somebody who can, with whom I can talk about the post-COVID symptoms, I mean, I would love to talk to that as well. But that's specifically after this presentation, I would be very excited to talk about cytokine storm, especially since we have experience with CAR T treatment, and I think it's very relevant to this situation. I do.
Sure. Where is the pandemic now in Kazakhstan? Is it dying down? Is it steady? Where are you all in the peak?
Well, the country was in lockdown, was in quarantine until May 29th, and then it was relieved. And Kazakhs are very social people, and everybody started partying, hugging, and then exactly after 14 days since the release of the lockdown, epidemic started rising the curve. And I think that the most probably difficult time was in mid-July when we didn't have enough hospital beds, and the staff was overwhelmed. There was no reasonable treatment, and that was very, very difficult, very challenging at that time. So now it's fading. Now the situation is much better than 2 weeks ago. And the death rate is going down. It was pretty high about 2 weeks ago. As you know, this death rate is lagging from the infection rate. So now its situation is much better. So it seems to me the government is took this under control, and we hope that it will be much better in the upcoming few weeks. So the government now is contemplating about taking next steps to to ease up the situation in Kazakhstan. But yeah, 2 weeks ago it was terrible. We exactly like in Mount Sinai, although you put the tents in the Central Park, but the government, the city government of Almaty, they set up beds in the sports center, and they engage several other facilities because there's not enough hospital beds. Of course, the same thing. ICU was completely crowded, and there's no ventilators. That's exactly. I mean, I followed the New York situation because my son lives on 84th Street, very close to Mount Sinai, and he kept telling me about these tents in Central Park and how situation horrible was. But we now very pleased to see that the death rate is very low now in New York City. So it seems to me whoever, Andrew Cuomo or de Blasio taking more control, but mostly physicians, of course. Yeah.
No, that's wonderful to hear. I'm glad things are better. I think we are getting ready for a potential second wave in fall when the flu season usually comes around October, November. As we have opened up socially in some other states in the South, like Florida and California, Texas have seen a wave of COVID. Our schools will open up in the fall, and
in New
that's
York,
a
decided.
concern. At least all the private schools will open up. All the public schools are going to have a hybrid system of some days of school, some days of at-home education. And that's the next concern, whether that will also cause a second wave. So we are preparing for all that, I think, and hopefully it won't be as bad.
Okay.
But in any case, let me start my presentation.
Yeah.
I think,
Dr. Parekh, let me check that everybody can see your presentation. Коллеги, вы все видите, да, презентацию доктор Parekh на экране?
Я думаю, что все видят.
Все видят, да? Да, просьба, может, микрофон временно отключить, тогда хорошо, чтобы это, не было посторонних шумов. Okay? Okay, I think we're ready, Dr. Parekh.
Great. So I think this is just to give you a idea of the scale of the problem that we faced and the particular question that we were interested in addressing in the study. So the problem, one of the many problems with COVID is that it's a very heterogeneous disease. There are some people that get sick with it. About 20% of the adults we saw had COVID that required oxygen support. 80% of the patients otherwise were managed as outpatients. They were not hospitalized. They were actually told to stay at home. And most of the time, we didn't even test them. Now there's more testing available. We even have rapid testing, which gives us the COVID results in 1 hour. For our chemo patients, especially, it's very useful. So we have more testing opportunity now. So we are able to capture these asymptomatic or mild patients, but our focus was actually on the patient with more moderate disease, as defined as patients requiring oxygen support or having abnormalities on CAT scan or other imaging of the chest. Some of these patients ended up in the ICU with even more severe disease, resulting in end organ damage or sometimes death. As I mentioned before, the total number of patients we had was several thousand, almost 7,000 here. We had 2,000 at one time in the peak, as I remember, in March, April. And within that, a subset was admitted to the ICU, about 20%, and our overall mortality was about 24%. Most of the deaths were associated with severe inflammation and also thromboembolic complications, as has been reported now very well in the literature. So our question was, could we use a test that could tell us at the onset whether a patient would get severe COVID or mild COVID? And this test was important because as the pandemic started in New York, many clinical trials were also started by a host of different specialties. Every specialty had drugs in it that were useful to block inflammatory reaction in patients. And these were then repurposed to test in the COVID setting to block different inflammatory pathways, different cytokines. The concern that we had at that time was that excessive immunosuppression can itself promote viral spread. We know this from bone marrow transplants, where if you give too many steroids or too many immunosuppressives, patients can then get secondary infections and ultimately die of the secondary infection, not graft versus host disease or even their primary cancer. So the idea was to create a systematic inflammatory blockade, which was very strategic and personalized for each patient. without compromising antiviral immunity. And this is sort of the paradigm that we are trying to build with information. The information that we first received, and this was again completely by chance, we had a system in place using a machine called Protein Simple. It's a benchtop analyzer for looking at cytokines that we had piloted for the cancer patients getting genetically engineered T-cell therapies. And this is a nice setup because it's inexpensive. It requires very little serum. It requires very little training or standardization, and the results are available quickly. We were using a panel that we had used for the cancer patients initially. I'll show you later how this panel was useful and how some of the analytes might change in the future as we learn more about cytokine storm. This was initially a research test, so to use it in the COVID patients, we had to actually ask our pathology colleagues to transfer it as a clinical pathology test that could be run for all the admitted patients through the hospital, and it could be prescribed in our hospital information system as a regular test as the patients got admitted. So with that, we tested in this report 1,400 patients that initially were tested on hospitalization, and a small number were tested as they went through their hospital course. And Diane, who's a colleague in the immune core, along with Sung-Hee Kim, put together the LR results with clinical outcome. And I'm happy to say the head of the immune core, Sasha Nyatik, and I have now a paper that's accepted in Nature Medicine. So what we first found was that the 4 cytokines we measured were looked at in COVID patients, healthy donors, and CAR T patients. It turned out that the cytokine elevation in COVID was very similar to the CAR T patients that also had cytokine release syndrome. A subset of the CAR T patients, as you may know, have a similar cytokine release characterized by fever and sometimes even neurological symptoms. So we have been following these patients, and we use them to calibrate the machine to say what is high and what is low in COVID, and we were able to establish thresholds. Using these thresholds, we then correlated the outcomes in the COVID patients with the cytokine levels, and we found that each and every one of these cytokines, if they were elevated, was associated with worse survival. So it could actually tell us if these patients were going to die. And I will tell you in the paper, it comes out that of all of them, IL-6 turns out to be the most powerful, followed by TNF-alpha and IL-8. IL-1 beta was less powerful, and it has a small dynamic range in the serum. I suspect this is a very important cytokine, but it's important at the tissue level in the lung or other affected tissues when you look at them. We were measuring it in the peripheral blood serum, and I think we may replace this with another cytokine in further versions of the assay. But this was completely eye-opening because our measurement was compared to standard things that we had available in the hospital readily, such as C-reactive protein, ESR, D-dimer, and other tests that people use for looking at severity of COVID in terms of inflammation. We were also able to follow a subset of patients longitudinally that had received different treatments. And you can see the effect of the different treatments. It's interesting. We used actually a receptor blocker for blocking the interleukin-6. And when the receptor is blocked, we see a paradoxical increase in the IL-6 levels initially, which is then followed by a decrease. When we gave patients steroids, there was a clear, distinct decrease in the level of inflammation. similar to remdesivir, which we also had on clinical trials at that time. You can see in contrast, drugs like hydroxychloroquine and others did not really affect decrease in the level of the cytokines. So using this simple benchtop assay, we could actually tell which patient was going to do worse and which patient was going to do better. Now we are trying to actually refine this test based on a more expansive panel of proteomic profiling. We are using a platform called the Olink platform, which can look at several hundred different cytokines at the same time. And the reason we are able to do this is that we had again started using Olink for cancer and other situations before the onset of pandemic, and we had it set up in the immune labs to look at inflammation from cancer, inflammation from skin disease, IBD, and other situations. What we found, this is 3 groups of patients with different degrees of severity. What we found in the top and lower group, these are the patients that had the most severe disease. The pattern of inflammation, of course, showed that IL-6 was very important and TNF was very important in the very severe disease. But there were other cytokines that are secreted by neutrophils that were also very important. In contrast, the moderate patients did not show an increase. Another important question that keeps coming up is, how are the children affected? You know, in the beginning, I have 2 small kids. I have a 1-year-old boy and a 7-year-old girl. And when I was deployed to the inpatient COVID management in April, I wasn't sure if going to the hospital was going to expose them for complications. And the pediatricians were very confident. They said, oh, the kids are not showing any sign of infection. We don't have a single child admitted to the hospital with COVID. We are managing them all outpatient. So don't worry, you can go and take care of the inpatients without a problem. Since then, everyone around the world has this experience where a small number of children have a multisystem inflammatory syndrome called MIS-C that resembles very much adult patients with COVID. So in this slide, I'm illustrating some results from other immunology colleagues, Dusan, Bruce Gelb, and Sasha, where they compared our patients with COVID, shown in pink here, and their cytokine levels to children with COVID, shown in yellow here. And you can see the children with COVID who had this severe cytokine storm actually had similar or even greater levels of cytokines as compared to the COVID patients that were moderate to severe disease. This is very important because it suggests that they share common physiology. Earlier, the children were supposed to have immune disease, Kawasaki syndrome, but now we know that this is slightly different, and the pattern of cytokines also confirms this is more similar to severe adult COVID. Interestingly, our labs at Sinai were also one of the first to actually come up with an antibody test based on the spike protein that could be not just a yes or no answer, but also quantify what was the level of antibody that was associated with COVID infection. And we compared the levels of antibodies in the adults and found that the children who developed this inflammatory syndrome had a similar antibody level that was resembling adult convalescent COVID-19 patients. And this is very important because this suggests, again, a common pathophysiology. You can see here, if we look at the subtype of the antibodies, most of the children have IgA and IgG antibodies, less so IgM. So this is important. This is now also another manuscript that's going out for publication. But I will tell you, the good news was that most of the kids that were admitted to the ICU received IV immunoglobulin and recovered. So this was a severe illness in them, but it was not as associated with mortality as adult COVID is, and could be reversed with IVIG. So with that, one question that comes up frequently is, why do we have the cytokine storm? What is the cell that is causing the cytokine storm? This is true, and this is similar actually to the CAR T patients that have cytokine storm. We find that in the COVID patients, there's lymphocytopenia. So the lymphocyte levels are actually decreased. The cause of the cytokines, we believe, could be actually the monocytes. So when we analyze the monocytes based on activation markers, you can see compared to control that are healthy individuals, we see a greater activation of the monocytes in the COVID patients. And this is something we've seen also in the cancer patients that are getting CAR T. So COVID and CAR T both secrete the cytokines from the monocytes. And in fact, there are ongoing trials of antibodies that are specifically blocking monocyte-released cytokines. The last slide I would like to show is actually all the different people in our immune monitoring core that worked hard for this project. The immune core is run by a very famous immunologist, Dr. Miriam Mirad. She's a friend and colleague who really was a dynamic force in setting up all the different people to do this, even while COVID was affecting rest of the hospital and the practices. Sasha is the associate director, along with Sungi, of the immune monitoring core. And I'll show you just one more slide of all the teams of volunteers. These were students in our PhD and MD programs that were supposed to be at home, staying away from the infection, but they volunteered to come in and help consent patients, take their samples, label them, get them analyzed and processed. And that allowed us to actually make this study possible. So with that, I'll stop and take questions. So back to you.
Thank you so much, Dr. Parekh. This is very interesting. Before my colleagues will think about specific questions, let me ask you a couple of them. So your panel for several cytokines, is it ELISA-based or is it a different technology that is used? And second one, were you studying also interferon gamma as part of cytokine system?
Yes, so this is a microfluidic technology that is not ELISA-based. We have compared it with ELISA-based technology when we first implemented it to look at CAR T patients, and the results were very, very comparable. We've also compared it to the more extensive proteomic platform, the O-Link platform that I mentioned earlier, and the results are again very consistent. That's why I like the panel and the platform. It's inexpensive. Actually, based on this work, there are many hospitals around the US and in China and Europe that have taken the machine and started analyzing their own patients. I'm not sure, maybe I can ask you a question. Have you all been banking patient samples for this sort of analysis? Do you have like a integrated effort at your institution or in Kazakhstan, maybe as an integrated effort for the country to bank patient samples for future analysis? Because this could be, something of a collaboration we can even think of going down the line.
Well, I'm not sure about COVID-19 patients, but there's a large project on personalized medicine that the health ministry is considering, is to collect samples from different kind of patients, including cancer patients, But with respect to COVID-19, I'm not sure. Maybe our colleagues know. Махаббат, там, do you collect samples? Вы собираете, да, образцы крови от пациентов COVID-19?
Мы на английском. We collect cases with COVID-19, but we had only about 300 patients because we worked as a COVID center only 6 weeks. And our center main direction cardiosurgery and cardiology care. And we started cardiology-surgery care from this week. And я хотела поблагодарить просто профессора Алмаз. Я могу с ним, да, выйти в диалог?
Да, конечно.
Thank you for your very excellent presentation because it's very interesting for us. And I have some questions for you. And how often we can see cytokine storm in late stage of this disease? After, for example, after 25th days or after 30th days, because for example, my sister, my younger sister, has COVID-19 pneumonia, and after 30 days, I saw Icahn 6 states. It's very I don't know why. Can you, what do you think about this?
Yes, so I think your sister's example is very good. It actually parallels my personal experience in the inpatient COVID floors, where we would have patients that had the acute infection. If we define it by PCR positivity in the swab, they would actually become PCR negative and still have the immune cytokine storm. So, the actual start of the COVID infection is not exactly known in most patients because they may be having it few days before they even become symptomatic. But if we track with the PCR test, we do have patients that are PCR negative and still have classic cytokine storm several weeks out of the initial reaction. This is not classic, but it does happen. There are patients that are continuing to have evidence of cytokine storm in terms of symptoms, lung symptoms, cardiac arrhythmias, chronic fatigue syndrome, even months out of the COVID. So we know that cytokine storm generally occurs a couple weeks after the acute COVID, not concurrently necessarily. So we have to probably say that they are staggered, and the acute infection and the cytokine storm are staggered.
Махаббат, не слышим тебя.
Sorry, I think you may be muted.
Я выключила микрофон. What do you think about user in the severe in this patient, but in late states? After, for example, 2 weeks from started this disease. This help for our patient or no? Because in our country we have remdesivir for this patient with COVID-19, but we started this therapy only 2 weeks ago.
I think that the clinical data on remdesivir showed the decrease in number of days in the hospital, but not a decrease in mortality. I think my experience is similar that it is a useful drug, but overall its effect is somewhat weak. So I think it may be useful more early on in more severe patients. I'm not sure it changes the course dramatically. Like intubated patients don't get extubated the next day after giving remdesivir. But it does have an effect that's beneficial. You saw in the slides I presented that the cytokines do get suppressed. So it has a weak antiviral effect. And I think if it's easily available, if it's not too expensive, it's not very toxic, it can be a useful adjunct to the treatment. We have several treatments right now. We have steroids, which are really useful in severe disease. We have remdesivir. We have antibody therapy such as tocilizumab, anti-IL-6, and others. We have convalescent plasma, which again we have on clinical trial and has some adjunct value, but has not dramatically changed the course for most patients. I think we used to in the beginning use, unfortunately, before knowing it was not helpful, hydroxychloroquine. Probably gave it to thousands of patients at the onset and did not really find much benefit. These patients got it in the outpatient setting. They would continue to take it inpatient. Probably some of them even got cardiac arrhythmias and died. May have done harm, but I think that the reality is none of these treatments completely alter the course of COVID for very severely sick patients. The mainstay is still number 1, 2, and 3 is oxygen, 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 and that unfortunately is where we are until we really have more scientifically guided trials telling us which patients to treat, and of course a vaccine that's useful.
Mahabat, не слышно. So there is no magic bullet, huh? Only combination.
I'm sorry, я забываю все время выключить микрофон, да? I'm sorry. How a long time we must use steroids after acute period of COVID-19? How long time? 2 weeks after discharge, or maybe 1 month? Maybe this depends from
so we are recommending a taper. That's a good question. We are recommending a rapid taper within the first 2 weeks for patients that are clinically improved. If they have not improved clearly, it may warrant a longer immune suppression. But again, remember, it's a two-edged sword. The longer you're going to keep people on immune suppression, they can get secondary infections that may then cause the patient to get sicker, and then you have to deal with that. So our policy, at least, has been on discharge to taper off the steroids as the patient gets discharged.
Okay, thank you. Maybe my colleagues have a question for you.
Sure.
Доктора, пожалуйста, задавайте вопросы. How we detect virus, coronavirus in human in last period, after 4 weeks, for example? Can we detect this virus in organism inside? No? Or only 2 weeks from first day?
So I will, we have another paper that's actually published already in the Journal of Hematology and Oncology. You can look for it with my name. So we have studied viral clearance in our myeloma patients. We had about 60 patients that we followed and looked at how long it took them to clear the virus. Clearly, this is a more immunocompromised subset, so a little bit atypical, but on average, they took 4 to 5 weeks to clear the virus. And I think that the virus clearance does not correlate with clinical improvement. So the patients can improve very quickly. We even had healthcare workers all over the hospital that are being monitored in a separate study. I can tell you a little bit about that study too. But the clearance can take several weeks, and we can continue to see evidence of the virus in individuals. Yes.
Mm-hmm. What do you think therapy with tocilizumab? Because we have some cases when we use tocilizumab, and it's very sick for our patient, because one patient after therapy tocilizumab had sepsis.
Yeah, so I think the biggest takeaway we got from our colleagues in Italy was that they had used tocilizumab in over 3,000 patients in Italy. And their impression, they have not published all the data yet, but their impression was that the patients that were pre-intubation, so a little bit earlier in the disease course, benefited more. The patients that were peri-intubation, like within 24 hours, if they got it, some of them could get extubated. So giving it a little bit earlier was probably more helpful. Based on this, we've started using it in the hospital on patients, similar to how we use it in CAR T. Again, it is still unclear if that's the best population. There have been several studies now, even on IL-6 inhibition with similar medication called sarilumab, which is not tocilizumab, but similar antibody that showed negative results. So I think we have to still define the population that of patients that benefits from this versus, like you pointed out, there's a population that gets this and then gets immunosuppressed, gets other infections and suffers. So this is precisely the point of the data that we are trying to generate in this project, that we figure out for which patients we need to give TOSI based on a biomarker guided approach rather than just giving it based on all comers or availability or clinical severity measure.
Thank you. And do you use in your experience high flow ventilators? High flow ventilators. High flow.
We do, yes. We use it a lot, actually. We use it as a bridge between the non-rebreather mask and intubation. Most patients would go through high flow, and then if they got better off high flow, they avoided intubation. I think that was a very nice sort of way of avoiding intubation in a lot of patients.
How many patients after COVID-19 need in active rehabilitation?
Sorry, could you repeat your question?
How many patients after COVID-19 need in active rehabilitation? Because we have in our experience, some patients oxygenotherapy depend after discharge, and for this patient, I think needs very active and long time rehabilitation. Maybe this patient will be as candidate for lung transplantation.
Yeah, that's a good question. I think in our experience, sort of at the peak of the COVID pandemic, our policy was the admission and the discharge of the patient depended on whether they needed oxygen therapy that could not be given at home. So they all got admitted when they got hypoxic, if the SpO2 dropped to 91% or so. They got discharged when they were keeping their oxygen saturation, above 95%. on some small supplemental oxygen or not, they would go home with an oxygen pump and oxygen cylinder and set up for home. But they continued to need it at home, just like you are pointing out, in the vast majority for several weeks after, which is okay. If they continue to need oxygen, that's fine. There's a subset of those, and I don't know how many exactly, that continue to have symptoms of persistent hypoxia due to lung scarring. But these patients are now being followed by the pulmonary clinics, and then the decisions are being taken, such as what you're suggesting, that if they don't recover and they need high levels of oxygen, they will ultimately benefit from lung transplant.
Do you have your experience lung transplantation after COVID-19?
Not my experience, but I think you must have seen the reports of that. There have been several reports now showing that it can be done and it may be beneficial. But again, I'm not a pulmonologist, so it's a little bit out of my.
I think it's in Michigan. They did double lung transplantation after the COVID. It was, I think, about a month ago.
It was Almas.
Yes.
So it was a successful lung transplantation after COVID. Yes, successful.
Yeah, I'll send you the paper. It was about a month ago when they transplanted. That was a lung fibrosis patient. There may be several more. The only thing I know is it's about this, I think Michigan or Illinois study. They've done it.
If I flip the question another way around, I think several of y'all are cardiologists or cardiothoracic specialists. When I was treating the COVID inpatients, we received patients that were having transplants, either kidney transplant, liver transplants, and so on, and were on chronic immunosuppression. And they seem to be definitely predisposed to having much more severe COVID. Did you see that in your transplanted population?
Let me introduce our cardiosurgery, Timur. Timur, ты слышишь нас? Timur?
Yes, I can hear you very clearly.
Ага. Timur, пожалуйста, please, question.
I beg your pardon, but could you repeat the question, please?
Did you see an increase in COVID in your transplanted patients who were on immunosuppression?
I didn't get it very well. Did we see what?
More COVID or more severe COVID in the organ transplant patients that were receiving immunosuppression to prevent graft rejection.
As I get it clearly, did we see more severe patients who received a much higher immunosuppression? Actually, we didn't do any transplant for that patients, so I can't say nothing about that.
Thank you.
But if it is possible for me, may I ask you a couple of questions?
Of course.
So about the late onset of the cytokine storm, as I get it, it is possible, right?
Yes.
And what are your thoughts about the reasons for late onset of cytokine storm? I mean, if it happens at late stage, does it has a viral nature or maybe other reasons? Because of that, the treatment will be different. So what, regarding the question that Dr. Mahabat asked you earlier about her sister, so the late onset of cytokine storm, if we can call it a storm, but cytokine release syndrome, maybe not as strong as at the earlier stage of the disease, but still, at the late stage, does it has a viral nature? Or maybe some other reasons?
I think that the virus plays an important part in the early initiation of the cytokine storm. After the monocyte macrophage system gets activated, it can secrete cytokines that then ultimately cause a vicious cycle that activates in turn T cells and then activates neutrophils and other immune cells to then go and cause tissue damage, which releases more cytokines and keeps propagating. So this occurs independent of the viral load. I think the initial portion of the storm depends on the virus to start off the storm, but the late portion is independent of the virus. As I mentioned, we even see it in patients that clear the virus.
It's more like chain reaction.
Right. And
like a chain reaction.
Yeah.
Very good. Yes, I think that's a good similarity.
Chain reaction. And the treatment would be not viral treatment, not specific, but inspecific.
Which
treatment.
is why steroid,
Correct.
And, the randomized studies have shown that the steroids helped patients that were intubated. I mean, that was the population that benefited.
Dexamethasone.
Dexamethasone. We were giving it actually both early and late. The patients that had, COPD or asthma and things and came in with COVID used to get steroids because the lung doctors felt, hey, this will help them with their lung function, but probably didn't help at that time. It would help them only if they developed more severe lung infection or more severe lung CRS.
Timur, may I ask you to address this anticoagulant treatment if Dr. Parekh can help us, since you have extensive experience with heparin, with low molecular anticoagulants, so maybe you might be interested in that specifically.
Well, our experience is mostly with heparin, and in our ICU we use only heparin for intubated patients and not intubated, but with high flow ventilation, and especially for ECMO patients, only heparin. But for patients in regular ward, we use low molecular weight heparin, and half of them were used regular heparin. But we prefer to use regular heparin because it is very easy to use. You can control it and you have antidote for that drug. And we believe that this drug is much more helpful than low molecular weight heparin. So our prefer is not low molecular, but regular heparin. And for example, when we discharge a patient from ICU, of course, we do it with low molecular weight heparin, but only when the patient is well active. But until that, we use regular heparin, continuous IV infusion. And we control.
So, Dr. Parekh, is it something that in your practice as well at Mount Sinai, because this anticoagulant treatment came relatively late? I mean, of course, maybe earlier than dexamethasone, does it have to do any with cytokine storm? Does it affect, or it took completely independent treatment?
No, I think that the cytokine storm causes endothelial activation that leads to the thrombosis. That's the pathophysiology. But at Sinai, it was interesting. While we were starting the epidemic, the ICU doctors actually noticed in a few patients that were severely ill, intubated, that they responded to thrombolysis. So TPA reversed anticoagulation and the patients got extubated. So that's when their thought turned that, okay, one of the side effects of COVID is macrovascular thrombosis, which needs the anticoagulation. Then we started anticoagulating patients, but the way we were doing it was not for all comers the same way. We did it for patients that were at higher risk using a D-dimer as a distinction. So for the patients on the floor, everybody gets low molecular weight heparin or regular heparin sub-Q prophylaxis for DVT. We would escalate that to full dose or treatment dose prophylaxis if they had high D-dimer, which would suggest greater propensity for thrombosis. And in the intubated patients, then the ICU had their own protocol, either using heparin drip or low molecular weight heparin as the treatment dose if the patients could take it. But we use D-dimer. I don't know if your experience is similar, if the use of D-dimer is useful in trying to figure out who would benefit from full dose versus prophylactic dose heparin.
What do you think about use anticoagulation therapy after discharge? For example, rivaroxaban.
Again, like steroids, we are not giving it long term because this also has, tendency to cause problems if not monitored and given. So if the patient's clinically improved, we tend to give them 1 to 2 weeks and stop it.
Mm-hmm.
Can we use about steroids, right? This is about steroids, but I understand.
No, an anticoagulation. Don't give it long term.
And after discharge, how do you monitor those patients? Again, D-dimers, or like when they go back home, then what do you do to monitor?
We don't continue the anticoagulant long term. It's just for a week or two after they get discharged.
Mm-hmm. Mm-hmm. Can you use aspirin for this patient after discharge?
Sure, I think that's fair.
Mm-hmm. And one question from our colleagues about fibrinolysis in early stage of COVID-19.
If the patients have evidence of severe PE or microvascular clot that would help them, I think it's a good measure. I don't know if that addresses your question.
So related to this, in many clinics in Kazakhstan, CAT scan is extensively used as a sort of criteria for hospitalization and discharge. As a monitoring tool, CAT scan is inexpensive relatively in Kazakhstan. And they use several criteria as a percentage of lesion in the lung tissue. And so, do you have such experience? And do you also recommend CAT scan as a measure to diagnose and to hospitalize and to discharge?
CAT scan as a way to diagnose or hospitalize, yes. As a way to discharge, probably no. I think we were using the clinical improvement as a discharge parameter, not CAT scan findings, because the CAT scan can continue to actually have abnormalities several weeks, sometimes even months after the COVID infection. I don't think it's reasonable to keep the patients in the hospital until the CAT scan improves.
What do you think about reinfection with COVID-19?
We have so far not seen even one patient get a second infection.
Okay.
Keep my fingers crossed. I have a question, Dr. Parekh. So we discussed extensively the tocilizumab and other similar medications. Those are kind of long-term, and assume that they directly affect interleukin-6 and maybe some other cytokines. Do you have experience with the other similar drugs like anakinra and those kind of medications that more short-term and would have less side effects? Are there any drugs that you can directly affect other cytokines such as TNF and interferons to sort of more precisely? You mentioned about precise medicine, but you mentioned in terms of selection of patients for precise medicine. But in this case, can you precisely affect specific cytokines using your like, you know, this multiplex panel as a monitoring tool?
Yeah, so I have a paper on anakinra use in CAR-T, which you can read, but we do use anakinra a lot. It blocks the IL-1 signaling, which is important, again, at the tissue level. And the nice thing about this is that it crosses the blood-brain barrier. So especially in the CAR-T setting, when patients get evidence of neurotoxicity, they benefit from anakinra. Um, and this is really quite easy to give. It's given as a quick injection every 8 hours, and it complements the IL-6 inhibition in CAR-T setting. In the COVID setting, we've given it to a few patients, but again, until we do large-scale trials guided by these cytokines, we cannot say we have a subset of patients that have been identified that will benefit from this therapy. One of the limitations of a cytokine panel was that it's a peripheral blood panel. Pairs like bronchoalveolar lavage, which we are also testing for cytokines to understand if the tissue level cytokine modifiers. You also mentioned another important cytokine that came up reliably, and in fact, when it was high, it was associated with mortality, was TNF alpha. And TNF alpha inhibition is being used therapeutically in rheumatological diseases all over the world. It is very easy to get, actually, both as sub-Q and IV injections. And we did use it on a few patients that had COVID in the hospital, going study blockade with IL-6 blockade. And I am waiting anxiously for the results of those studies to see if they would be guiding us in which patients to use this combination blockade.
This is your
Timur has a question for you.
Yeah, please go ahead, Timur.
Timur.
Thanks. Late cytokine storm signs, and might be at earlier stage. I'm sure you have an experience with the cytosorption. I mean, extracorporeal hemofiltration with in addition with cytosorbents like cytosorb, or maybe Javron technology with HA330. And do you have such experience at early stage and maybe at a late stage of cytokine storm?
Yeah, I personally did not use it. I think the reports that show, and in fact it's now approved as one of the options in COVID, show that there's some benefit, but again, it does not seem to be a magic bullet, sort of like plasma or remdesivir or any of them. I think there will be also more morbidity in setting up these more invasive procedures. So I think it's definitely possible, but I'm not sure I have enough experience to say for or against using it earlier.
Good, thanks so much. And one more question, did you change treatment protocol at Mount Sinai on the basis of data your group got from those scientific information you mentioned above?
So far, this has purely been a research exercise. We are changing the panel that we are going into with the next wave of cytokine release. And the way we have used this panel in terms of correlative studies is that we had multiple clinical trials ongoing with different antibodies, TNF blockade, mesenchymal stem cells, anti-GM-CSF antibody. So all of these patients were also monitored for their cytokine patterns. And now we are analyzing the data about which patients responded, didn't benefit, and how their cytokines were different. So all of this is ongoing research. I think that will inform in the future. At the current point, it is still mostly a research exercise.
Okay, so as I got it right, you have a strict protocol and you still use the same.
Correct, because we have to prove that protocol driven by biomarkers is better than the clinically. Yeah.
Can you share with us your protocol?
Sure, I'm going to try to find a simple version that we can share with you.
Excellent, thanks so much.
Madina, question. Madina.
Okay, while we're looking for Madina, so I have another question related to your panel, actually, that is very exciting. So is there any way to, you mentioned a lot of similarities of cytokine storm related to COVID-19 with CAR treatment related cytokine storm. But is there any way to differentiate those as well as differentiate cytokine storm during respiratory distress syndrome or after trauma, those kind of things? So apparently it is quite broad spectrum of damages that cytokines can impose on the human, on the patients.
Yeah, so I think at the moment, the limited panel only tells us about the similarities between the cytokine storm. To look at differences, we need to use the more extensive panel, the proteomic analysis panel, that looks at several hundred cytokines, and that is very interesting. What we found even in the CAR T patients was that each patient's pattern of cytokine fingerprint from patient to patient, there are slight differences, even within the modality. So if you look with higher resolution, you do see differences between different types of storms and between different patients that have cytokine storm. But you won't capture it with a small analyte panel.
Yeah, that'd be exciting to see with a broader spectrum. So is Madina there?
Madina asked about psychologist care for patient for patient with COVID-19 after discharge. In your experience,
supportive care after discharge. Is that
yes.
Psychological.
Psychology.
Technology.
Psychology.
Psychology.
Psychology. Okay.
Yes.
Yes. So as I mentioned, we've set up a center for post-COVID care, which does involve a lot of supportive care in terms of psychological support and medical support. And the patients are definitely asking for it. So clearly this is a big need, and I've spoken to colleagues around the world where they have noticed that setting up even simple phone lines or phone-based apps that provide some sort of supportive psychological care is very beneficial, and a lot of patients are asking for it. So I think having a center like this is helpful for the patients. If you can't have a center, having a phone or a phone app that can provide this sort of support would be very important.
Interesting. So, Dr. Parekh, you mentioned about these pediatric cases of COVID-19, and they are more pediatric cases. So they more look like Kawasaki syndrome. So I understand from your presentation that those are let's say the pathophysiology of those cases are related to cytokine storm. So does it mean that the children must be treated with dexamethasone and similar treatment as adults with
they
cytokines?
received exactly similar treatments like adult COVID, except that the thing that seemed to make the difference was IV immunoglobulin on top of steroids and plasma and all that was given. The thing that really made a difference was IVIG.
Mm-hmm. Okay, we have someone else joining.
Almost one question from Sirop, please. Our cardiologist.
Good evening. Good evening.
Good evening.
My name is Sirop. I'm an interventional cardiologist. First of all, thank you for your presentation. That was really interesting. And as an interventional cardiologist, I would like to ask the question about which concern to the patients with ACS. As we know, the COVID is hypercoagulable state may lead to stent thrombosis. And personally, I didn't face these patients, but I read some reports particularly from Spain and from TCT side. There were the cases that that discuss these questions. So what is your opinion? Is there any need of potent antithrombotic therapy, or we should continue the way we know? So is there any need of some new therapy for these patients? Thank you.
I think the anticoagulant therapy, as we discussed before, is very important. I think for patients that had acute coronary syndrome while they were hospitalized, in our recollection, I think we treated them very similar to what you would treat them with ongoing acute coronary syndrome.
Dr. Parekh, we mentioned about sharing protocol, Mount Sinai protocol for inpatient treatment. But if you have something for outpatient treatment, that'd be great also.
Sure. I think there is a discharge sort of plan that I can probably find and share with you.
And also a copy of your presentation, please, if possible.
Sure. I think the paper will be better for everybody. You can understand the background.
Thank you.
Sure.
Dear Professor, thank you for your presentation. Can I ask you about some interesting cases? I have some patients with COVID-19
sure.
and with high temperatures that continued 3-4 weeks, despite the normalization, blood analysis, and X-ray. There was not any reasons for high temperature, and have you had some experience, and what do you think about the reasons of so high temperatures that continued 3 weeks? Thank you.
May I ask, what was the treatment given to these patients? Besides antibiotics, I guess?
Anticoagulant therapy, anti-aggregation therapy, and prednisolone, corticosteroid therapy.
Yes.
Yeah, okay. Steroid therapy.
And do you have any indication about markers of inflammation in terms of ferritin, CRP, things like that?
CRP was elevated, but a little bit, and other markers was negative.
That's interesting. So we saw this syndrome, which resembles very much histiocyte activation, HLH, in patients that had COVID, severe COVID going on, and had hyperferritinemia. So if we check the ferritin in these patients, sometimes they had ferritin not just in thousands, but in tens of thousands, which is very typical, almost diagnostic of HLH. And there, patients would get persistent high fever day after day. I suspect that that may be what you are describing in your patients.
Yeah,
What do
maybe.
you think?
Thank you.
I'm sorry. What do you think about activation CMV after COVID-19?
We did see a lot of secondary infections in these patients as they got immunosuppressed. So CMV was one of them, but also a lot of bacterial superinfection.
This patient needs special antiviral therapy or no?
Only if they have CMV PCR going up. We did not use CMV prophylaxis.
Okay.
Okay.
Another question. Our colleague, Almas, a lot of time. Yes?
Yeah.
No?
Yeah, I think like Dr. Parekh is busy now. So do I have more questions, colleagues?
Hi.
Hi.
Yes. Okay. Last question, please.
Yeah. Thank you. I'm a pediatric doctor. I want to ask about your patients, pediatric patients and children. My question about vibromassage, vibrolung. Do you use vibrolung during cytokine storm?
I'm not sure I know what that is. Can you tell me a little bit about it?
Vibromassage. Vibromassage, vibrolung.
I'm not familiar with that. I'm sorry. Maybe my pediatric colleagues would be able to address it. If you could email your questions to Almas, and you can forward them to me, and I'll try to get as many of my colleagues to write back to you to answer different specialties that have specific issues.
Okay, thank you.
Dr. Parekh, I would be happy to coordinate that, and I'll collect more questions. And I really appreciate, we all really appreciate your time. I think in your very busy schedule, and I think you shed a lot of light on very important issues here and management of these severely ill patients. Really appreciate that. So we look forward
to your invitation, and I really appreciate so many people showing up and asking questions, participating. Hopefully it was useful.
Yeah, we have 31 people joined us.
Bye-bye.
Dr. Parekh, a quick question on that interview. So do you think that next week would be possible? Maybe I should work through Jennifer, or what would be the best arrangement?
Yeah, why don't let's do it over email, and I'll also try to find somebody from the post-COVID center to help with this.
Wonderful.
And let me introduce your invite for Kazakhstan after ending pandemic.
Yeah. I know it's
our
a beautiful country.
National Cardiosurgery Center.
That is very nice.
Welcome, and thank you for your presentation and for your time. Thank you.
Thank you.
Okay. Bye. Have a nice day, everybody. Okay, Dr. Parekh. See you.
See you. Thank you.